morning, everybody. Today we are going to discuss cutaneous tuberculosis in short. You must have studied tuberculosis in medicine, and we are only going to discuss cutaneous tuberculosis. The causative agent is say Mycobacterium tuberculosis, which causes other tuberculosis in other body parts. As you know, it is non-motile rod-shaped bacterium. It is obligate aerobe and facultative intracellular parasite. The classification of cutaneous tuberculosis. Cutaneous tuberculosis means the tuberculosis of skin. The skin tuberculosis can be classified on the basis of route of transmission. The first of all, inoculation tuberculosis. It is the exogenous source. Inoculation tuberculosis means the tuberculosis is inoculated from the outside source. The inoculation tuberculosis are lupus vulgaris, tuberculosis verrucosa cutis, and primary inoculation tuberculosis. The second is secondary tuberculosis, means endogenous source. Tuberculosis transmitted to the skin from internal sources, internal organs. The diseases are scrofuloderma, orificial tuberculosis, and the third one is hematogenous tuberculosis. In this, the skin tuberculosis is transmitted from a hematogenous route, from the blood. The examples are acute miliary tuberculosis, tuberculous gumma, some cases of lupus vulgaris, and the fourth one is tuberculates. Tuberculates are the hypersensitivity reaction to the Mycobacterium tuberculosis. The examples are papillonecrotic tuberculate, lichen scrofulosorum, erythema induridum. The diagnosis of tuberculosis is same like other tuberculosis diagnosis. In addition to that, we also do culture of the culture and histopathological examination of the skin. The same. If you suspect tuberculosis, you have to do chest X-ray, sputum FE, man-to test, FNAC, and polymerase chain reaction. The polymerase chain reaction that is most commonly performed these days are gene expert, which is almost done in every cases. We can do interferon gold assay also. And the culture is the standard method of diagnosis, but it takes 4 to 6 weeks for the organism to grow in culture. The culture medium is Lowenstein-Jensen media. And the tuberculin test, that is the man-to test. In this, we give 0.1 ml of PPD, purified protein derivative, that is injected intradermally in the forearm, and the reading is read after 48 to 72 hours. Now, it is considered positive if it is more than or equals to 5 mm in person at high risk for tuberculosis, and more than 10 mm if the person is at risk for tuberculosis. Person at high risk of tuberculosis means patients with chronic disease like HIV, a patient with recent exposure to tuberculosis, patient with findings on radiographs suggestive of tuberculosis, and employees of hospitals and long-term facilities. And person at risk of tuberculosis are the injectable drug users, person in close living conditions, persons born in countries with high prevalence of tuberculosis, and it is considered positive if it is more than or equals to 15 mm in the people who do not belong to either of these two groups. And we have already discussed quantiferin TB gold test, PCR, that is gene expert. A PCR is also important for the diagnosis of drug resistance. And in histopathological examination, in early examination, we find non-specific inflammatory changes, but after 3 to 6 weeks, the fully formed tubercle is seen. Tubercle consists of a focus of epithelial cells containing Langerhans cells, and these cells it is surrounded by infiltrate of mononuclear cells, and in the center of tubercle there is a caseous necrosis. Now the clinical features. First of all, primary inoculation tuberculosis. It is also called tuberculous chancre or tuberculous primary complex. It results from the inoculation of Mycobacterium tuberculosis into the skin of an individual without prior immunity to the organisms. It is a multibacillary form, and the bacillus enters in the skin through abrasions, minor injuries. Common sites are face, limbs. It is more commonly seen in children. It is also seen after ritual circumcision and infection with syringes, wounds, operations, ear piercing, tattooing, and mouth-to-mouth respiration. It can also be transmitted following insect bite, and sexual transmission has also been reported. After 2 to 4 weeks of inoculation, there appears a brownish papule, nodule, or ulcer with undermined edge and a granular hemorrhagic base. Most common sites are face, hands, and lower extremities. There is regional lymphadenopathy also. If it is seen in nail folds, it may simulate paronychia, and there is mucosal involvement also. If it is seen in eyes, there can be conjunctival chemosis and ulceration and edema of lids. This is the tuberculous chancre in the lateral nail fold, which mimics paronychia. This is the typical tuberculous chancre with regional lymphadenopathy seen in the face of a child. For the diagnosis, one is the clinical suspicion, and the second, we can do AFP stain in the primary skin lesion and draining lymph node. Now the tuberculosis verrucosa cutis, it is also called warty tuberculosis. It occurs in previously infected patient with moderate to high degree of immunity. It is a paucibacillary form, and it is warty plaque-like form. Mainly, it is transmitted by 3 mechanisms. Accidental superinfection from the exogenous source, autoinoculation with sputum in a TB patient, and from a sputum by sitting on the ground or walking barefoot where the organism is present. Most commonly seen in hands, knees, ankles, buttocks. It starts as small indurated warty papule with irregular extension at the edges. That is varicose surface. It can be formed with soft areas expressing pus and maybe psoriasiform or keloidal. Psoriasis-like or keloid-like lesions can also be present. Now, in this picture, you can see tuberculosis verrucosa cutis with strong tuberculin reaction. It is 35 mm. Right? You can see warty plaque. It is also tuberculosis verrucosa cutis. This is also tuberculosis verrucosa cutis. This is another picture of tuberculosis verrucosa cutis. Now the scrofuloderma. Scrofuloderma occurs after the involvement and breakdown of skin, which overlies a contiguous tuberculosis focus. Most commonly, it is a lymph node, but it can also occur from the infected bone or joint and lacrimal gland or duct. It is most common form is secondary to cervical lymph node infection, and it is the commonest form of tuberculosis in children. In the clinical feature, there is bluish red nodule overlying the focus, which breaks down to form an undermined ulceration with granulation tissue at the base, fistula beneath the ridges of blue skin, fibrosis and fluctuation at different sites in the same lesion. You can see this is the bluish nodule overlying the infected lymph node. Okay? This is scrofuloderma. This is the cervical lymph node. These are the inguinal lymph nodes, and this is the scrofuloderma. Okay? There is ulceration also. This is also scrophulodderma from the infected axillary nodes, and this is also scrophulodderma from the in the chest. Now the orificial tuberculosis. Orificial tuberculosis is the tuberculosis of mucosa or the skin adjoining orifices in a patient with advanced internal tuberculosis. It is very rare, orificial tuberculosis, mostly associated with pulmonary, intestinal, or anogenital tuberculosis. It is a multibacillary form. Most common is the around the oral cavity. There is small edematous red nodules which break down to form painful shallow ulcers with undermined blue sizes and may be associated with granulomatous swelling of the lips. Pain is the cardinal feature of orificial tuberculosis. This is the picture showing orificial tuberculosis. It is the biopsy site. This is also example of another orificial tuberculosis. Now the hematogenous tuberculosis. First one, miliary tuberculosis. Miliary tuberculosis occurs with generalized miliary tuberculosis. It results from the hematogenous dissemination of mycobacteria to skin, and most commonly seen in young children and immunocompromised patients, that is HIV patients, or in the children following viral infections like measles. In the clinical features, there are profuse coughs of minute bruised papules, vesicles, pustules, or hemorrhagic lesions, which may undergo necrosis to form ulcers. There can be erythematous nodules also, and the tuberculin test is usually negative in miliary tuberculosis. This is the X-ray feature showing miliary tuberculosis, and this is the skin feature. You can see bluish red nodules with central ulceration. Now second one, lupus vulgaris. It is the chronic progressive post-primary postbacillary form of cutaneous tuberculosis. There is moderate to high degree of immunity in the patients, and it is the most common form of cutaneous tuberculosis seen. That is lupus vulgaris. It is more common in women than men. Origin is from the underlying focus of tuberculosis, either from underlying focus of the tuberculosis like bone, joint, lymph node, or hematogenous or lymphatic spread or contagious spread. And it can also arise from exogenous inoculation or as a complication of BCG vaccination. It commonly appears as a solitary lesion on a normal skin. Most common sites are head, necks, arm, legs, buttocks, and trunk. In the children, most common sites are lower limbs and buttocks. Initially, there is small reddish brown flat plaque with gelatinous consistency. On diascopy, the color appears like apple jelly nodules. Diascopy means we press the lesion with glass slide, and the color appears like apple jelly. Gradually, the lesion progresses to elevated, infiltrated brown, and it grows by slow peripheral extension to become gyrated or discoid with areas of atrophy. There are 5 general patterns of lupus vulgaris: plaque form, ulcerative and mutilating forms, vegetative forms, tumor-like forms, and papular and nodular forms. Now these are the pictures. You see erythematous plaque only in this. This is almost annular with peripheral extension. These lesions are also annular type of lesions with peripheral extension. And you can see there is areas of scarring in this lesion. You can see there is scar formation and peripheral extension. There is cartilage destruction also in this picture. This is also lupus vulgaris over nasal tip. And there is mucosal involvement in lupus vulgaris. Nasal, buccal, or conjunctival mucosa may be involved. Nasal lesions may ulcerate and may lead to cartilage destruction. Granulating, vegetating, or ulcerating lesions of buccal mucosa, palate, gingiva, or oropharynx can be seen. And there can be stenosis of larynx and scarring of soft palate also. Now, the complications of lupus vulgaris can be if it occurs around the eyes, it can be ectropion. If it occurs around the mouth, there can be microstemia. Sometimes SCC, squamous cell carcinoma and basal cell carcinoma and sarcomas can develop at the site of lupus vulgaris. Now, metastatic tuberculous abscess, which is also called tuberculous gumma. It results from the hematogenous spread during periods of lowered resistance. There can be single or multiple lesions. It occurs in malnourished and immunocompromised children. There is a form subcutaneous nodule or fluctuant abscess. Extremities are more commonly affected, and the overlying skin may break down to form and undermine also, or often with sinus. You can see this is the tubercular abscess or tubercular gumma. This is also the picture of multiple tubercular abscess. On palpation, you can see there is formation of sinuses also. Now the last one is the tuberculosis. Tuberculosis is the hypersensitivity reaction to Mycobacterium tuberculosis or its products. And the main features of tuberculosis are positive tuberculin test. There is evidence or manifest of current or past tuberculosis, and there is positive response to anti-tuberculosis therapy. There is absence of bacilli in skin biopsy specimens, and PCR may detect mycobacteria DNA in some forms. There are a few terminology related to tuberculosis. Tuberculosis appears due to either Mycobacterium tuberculosis or bovis, and the entities that develop are lichen scrofluorosorma, miraze, lichen scrofluorosorma, and papillonecrotic tuberculosis, facultative tuberculosis, which can occur due to Mycobacterium tuberculosis and bovis. And the entities that develop are nodular vasculitis or in erythema induratum of vagina and erythema nodosum. And there are non-tuberculosis also, which were previously thought to be due to tuberculosis, but recently these are not due to tubercular infection, like lupus miliaris disseminatus fasciae. Now the true tuberculosis are the micropapillar forms, that is lichen scrofluorosorm, papillar forms, that is papillonecrotic tuberculosis, and the nodular form, that is erythema induratum of vagina and nodular tuberculosis. In the lichen scrofluorosorm, there are asymptomatic 0.5 to 3 mm closely grouped lichenoid papules, which are usually skin colored, maybe yellowish or reddish brown, and they are perifollicular and appears in groups or in an annular arrangements or plaques. Papules may have adherent crust or small pustules and mainly found over abdomen, chest, back, and proximal limbs. These are the lichen scrofluorosorm. These are the micropapillar form of tuberculosis. As you can see, there are very small, almost skin-colored papules. In the papillonecrotic tuberculosis, there is symmetric eruption of necrotizing papules, which mainly affects the extensor aspect of the extremities, and the individual lesions heal with scarring. It occurs preferentially in the children and young adults. The sites of predilection are the extremities, buttocks, and lower trunk. There are disseminated crops of dusky red papules with central depression and adherent crust over a crater-like ulcer. And on involution, it leaves scars. In children, flagellated conjunctivitis may be present. Young adults are predominantly affected. but it can also be seen in infants and young children. As you can see, these are the papillonecrotic tuberculosis. Papillary lesions with central crust and ulcer formation. This is another picture of papillonecrotic tuberculosis on the forearm. And the third one is erythema induratum, in which the lesions are characterized by recurrent nodular and ulcerative lesions. It occurs secondary to tuberculosis elsewhere in the body. Usually it is localized to lower legs, but can affect other areas also. It is more common in women than in men. In the clinical features, there are ill-defined painful nodules affecting the posterior aspect of lower legs of young or middle-aged women. It may affect upper limbs, thighs, trunks, and buttocks. Lesions may also ulcerate. These are the pictures of erythema induratum of the legs. There are ulcerated lesions also. These are the nodular lesions. And the fourth one is erythema nodosum. It is the most common type of septal panniculitis. It may occur secondary to tuberculosis, but it can be idiopathic and secondary to other infections or other internal diseases like connective tissue diseases also, and secondary to drug therapies also. In the clinical features, there are painful erythematous nodules, which typically occurs in scenes, mostly scenes. It is bilateral symmetrical and ranges between 1 and 5 cm, and nodules may coalesce to form plaques. And after several days, the erythematous nodules flatten and become ecchymotic, which then take on a yellow-green appearance, which is called erythema contusiformis. Erythema nodosum never ulcerate, atrophy, or scar. It is usually present for 3 to 6 weeks. There can be other features like fever, fatigue, malaise. And these are the pictures of the erythema nodosum, which mostly appears over the seam on the anterior aspect of the leg. Now to treatment. Treatment of the skin tuberculosis is same to that of other tuberculosis. You must have already studied in medicine. The same guideline, which is formulated by the Nepal government. This is the updated guideline of 2019. If the skin tuberculosis, it is the skin tuberculosis only. There is no any other past history of tuberculosis or treatment cases. Then it is considered as new tuberculosis case, and we give 2 HRZD in the intensive phase and 4 HR in the continuation phase. You must know. You must have already known the drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. And the complicated cases, it is usually the complicated cases are in systemic cases. But as you have already seen, there can be skin tuberculosis in miliary tuberculosis also. So for these cases, we give 2 HRZD and 7 to 10 HRE. Right? This 7 months to 10 months HRE is given according to the clinical improvement. And in case of retreatment cases, in skin tuberculosis also, if it is retreatment cases, if it is rifampicin sensitive and isoniazid sensitive, we give 2 months of HRZD, which is followed by 4 months of HR, isoniazid and rifampicin. If it is rifampicin sensitive, isoniazid resistant and fluoroquinolone sensitive, we give 6 months of, it is usually we give rifampicin, pyrazinamide and ethambutol, but as you know, this isoniazid also comes in the same packing, same tablet. So the isoniazid is given in the packet form. Plus, we give levofloxacin for 6 months. If it is rifampicin sensitive, isoniazid sensitivity is not known due to the unavailability of the sensitivity test. Then we give 6 HRZD full duration. And if it is rifampicin sensitive and isoniazid resistant and fluoroquinolone resistant, we give 6. It is RZD, rifampicin, pyrazinamide, and ethambutol, but isoniazid is also given in bracket because it is available in the same package. So we give 6 HRZD. This is the national guideline. Our national guideline, which we follow the same treatment guideline for skin tuberculosis also. Okay, thank you. Any questions?